Good evening to this evening presentation. I think they have already introduced my names. My names are Cuthbert Mulenga. I'm a sonographer, radiographer. I'm currently working with Apex Medical University and the ultrasound department. So I'll quickly go through this topic, which is the assessment of the right heart side using echo. First and foremost, I know a lot of us, we are practicing echo, and we also have some beginners and also some experienced people who are practicing echo. And together we need to sharpen each other so that we can give the best to the patient. And more importantly, we also need to check some few things that are standard to practice echo, and even some few parameters that needs to be done when we are practicing this echo. I would love to give a brief overview regarding echo. There's nothing new that I'm going to say, but I would love to emphasize on some few things that has to be done for one to comprehensively do an echo and give the optimum results. It's very important. So or
you can just start from here. Go ahead and start from here. Thank you.
All right. So I chose this topic so that we can also look at the right side of the heart, and then I'll look at the introduction, anatomy of the left ventricle. We'll just remind each other. And then there are some few high-heeled concepts that I'll just remind on each other. I'll look at the 2D assessment of the right ventricle, assessment of the right ventricle function. There are quite a number of methods, but for the sake of today's discussion, I'll just discuss one. But questions are welcome to comprehensively discuss that. I'll also look at some few pathologies that involve the right ventricle. And lastly, I'll look at pulmonary hypertension and the atrial assessment. When you look at the right side of the heart, for those of us who are practicing echo, you agree with me that traditionally, when you are doing an echo, a transthoracic echo, we normally don't assess so much the right side of the heart. And okay, I can now have my okay. You can see it on slideshow.
Yes, I can go ahead. You can proceed.
Okay. So you also realize that traditionally we don't pay much attention to the right heart side of the heart, and the reasons could be related to some few anatomical reasons, and one of them is that the right side of the heart, particularly the right, it lies just behind the sternum, and this makes it so difficult sometimes to image with ultrasound. So you realize that sometimes it's a little bit tricky to actually see these structures. And the other reason is that due to the orientation of the heart, you find that it's relatively complex compared with the left. And by complex, I mean there are quite a number of structures within the right ventricle, things like the trabeculations that may actually make us difficult to assess and give accurate measurements. And then you also find that because of those trabeculations, sometimes the right side of the heart, and the fact that if the indication is actually not indicated to assess the right side of the heart, we don't do much of the things. So in this discussion, I just want to concentrate and also give some emphasis on some few points that we take sometimes for granted as we do an echo. So I'll start with the right atrium. So physiologically, the right atrium receives blood or venous blood from 4 inlets. One of them is the coronal sinus, that is the venous blood from the myocardium. And it also receives the blood from the upper part of the body, that is from the superior vena cava. It also receives blood from the inferior vena cava, that is the venous blood that is coming from the lower portion of the body. So physiologically, we have to have this in our mind that the right atrium is carrying blood from these portions. Even as we discuss this right ventricle, that physiological aspect has to come into our minds. So there are some few high-heeled concepts that needs to be understood as we do this modality, which is operator dependent. One of them is that when you are assessing the right ventricle, this is a general concept that needs to be gotten. When you are assessing the right ventricle, generally, empirically, when you look at the right ventricle, ideally, it should be less than the left ventricle in size. Just by looking, by eyeballing, that should be quick to be noted. Secondly, the right ventricle dysfunction can also be assessed when there is decreased tricuspid valve annular motion. I'll explain all these terms when it comes to the concepts. And you also find that you can also have reduced duration of the tricuspid regurgitation. Other things that you have to note is that the right ventricle pressure overload may actually cause the systolic interventricular pressure septo-flattening, and the TR, which is the tricuspid regurgitation jets. You can also find that you can also have RVOT notching. And by these terms, what I'm trying to emphasize, especially on this part, is that when you have the right ventricle pressure overload, I'll explain what this pressure overload is. You also have to look at specific things like you are going to have systolic intraventricular septo-flattening, which sometimes we call the D-shaped. I'll explain all these concepts and how they can help you to understand some few things. These are indirect concepts that you can look at even before you do certain quantification of echo parameters. So when you see a D-shaped in a right ventricle, what does it mean to a cardiac sonographer, to a sonographer? What does it indicate? What is the clinical implication? What are the hemodynamics that are happening there? This is why these concepts are coming in. And then things like when you see the right atrium pressure increase, what does it mean? I know a lot of us, we are practicing abdominal ultrasound, and we tend to find that sometimes the IVC is dilated. What does it mean to a cardiac sonographer? What are you supposed to indicate? Or if they happen to bring a patient for abdominal ultrasound, and then you find that the patient has got dilated IVC, can you actually recommend that this patient may need a comprehensive cardiac ultrasound? So those are some of the things that we need to look at. Things like the interatrial septal bowing to the left. There are times where you have the pressure increase within the right atrium. So some few concepts that we tend to see is basically looking at the anterior septal bowing towards the left. It can also give you a quick observation on what is going on. So what do we basically look at? When you are looking at the right ventricle, you have to know which windows do you see the right ventricle. And even if you see it, which is the best window where you can quantify the measurements, the parameters, and those hemodynamics measurements that you need to do. I should mention here that never conclude an echo report or echo diagnosis on one image. I think I've always seen, sometimes I see people just on 1 or 2 images, they conclude things. Yes, that is very much okay, but that comes with experience. But even then, learn to always comprehensively compare and quantify that particular examination that you are doing by doing possible maybe 3 or 4 assessments so that you come up with a conclusive report that is also valid. I will give a very, very simple example. There are times where you have a patient with the atrial fibrillation, and then they come to your echo room, and then you want to assess the diastolic dysfunction. If you only do the EA ratio, you are going to find that the EA ratio, they will be fusing. Why are they fusing? Because you have to understand atrial fibrillation, this is when there is uncoordinated electric impulses within the heart. So the EA ratio, they will be fusing. So if they will be fusing, it simply means you're not going to do your EA ratio. So what do you need to do? You need to switch on now on TDI, tissue Doppler imaging. You do your tissue Doppler imaging. Even when you do your tissue Doppler imaging, you can also do the volumes of the left atrium so that you can have at least the volume of the left atrium, the TDI, and when you are limited with your EA ratio, at least you can use these two parameters to conclude. The point I'm trying to put across is that don't conclude echo only on one image, because that can be so misleading. So these are some of the windows that you can be able to see the right ventricle in profile. And I won't go through those windows, but I'll discuss exactly what you need to look at. So first things first, you have to do the right ventricle dimension. And in the right ventricle dimension, you look at the cavity size, you look at the wall thickness, you look at the global systolic function, you look at the regional systolic function. You also look at the left ventricle masses, or if there are any thrombuses. So upon looking at this, you have to know the normal size. What is the normal size of the right ventricle? When do I measure? At what level do I measure? Do I do it in end diastole or in early systole? All those nitty-gritty of the technique, they are very key. When it comes to the global systolic function, which is the best parameter do we use? Do I use TAPS, or do I use fractional area change, or do I use what? So those parameters, they are very key to stick to that. When it comes to checking of the masses, am I dealing with a thrombus? Am I dealing with a tumor? Is it benign? That may not be our issue, but the key issue is that as you are assessing the right ventricle, consider the following that I've mentioned so that you guide the clinician even as they come. So just by eyeballing, for those of you who are practicing echo and you are experienced in this echo, just by eyeballing, you must remember that the right ventricle is actually 2/3 of the left ventricle. Just on a 2D echo, you are able to see that, oh, the right ventricle is within the normal range, even before you quantify. And quantitatively, you can also find that you can also do a 2D end diastole to do your measurements. And I'll show you how you can do and the methods that you can apply when you're doing that. You can also use the apical four chamber, that is at the basal level, right ventricle, how much does it measure? At the basal level, normal measurement, it should be less than 2.8 centimeters. And then at the mid-level, right ventricle diameter, it should be less than 3.3 centimeters. And at the base, towards the apex, when you measure the length, it should actually be less than 7.9. Actually, they can, others, they even go up to 8 around there. Those are the normal parameters for the right ventricle internal diameter of that. You can actually also use the right ventricle in short parasternal access. Now, when you look at this again, I'm just trying to give another view that can also help you to say, am I really seeing what I'm seeing? So you also go in your short parasternal access and quantify your measurements that you took in the other parameter. And then you can also measure the right ventricle at RVOT, that is the left ventricle outflow tract. At the level of the aortic valve, it should also measure a certain parameter. You can also measure the right ventricle at RVOT at the annulus level. It should measure around 2.3 centimeters. Again, you can also go further to measure the right ventricle at the pulmonary artery level. It should also measure around 2.1. I should mention again here that in practice, most of these measurements that we are doing here, we don't do them. But sometimes if there is a case that is particularly requesting you to assess the right side of the heart. You have no option but to actually go into it and do the actual thing so that you come up with something that is so tangible. For example, if the clinical question is particularly that the patient, they want us to quantify pulmonary hypertension, you have no option but you have to actually look at some of these things in detail and quantify them. Okay, my slides cannot move. Sorry, okay. Oh, my slides cannot move. Oof. Sorry. Sorry. Oof. Oof. You also have to make sure that you quantify all the parameters as per standard, and the view that is also recommended so that you get the corrective measurement. So when you are measuring the right ventricle wall thickness, normal should be within the range of less or equal to 5 millimeters, and it should be measured in end diastole, that is on the RVOT, or you can also use the palastenolong axis. The question is, where do you measure and at what level do you measure this? So RVO in the subcostal view, I'll show you the image. The parameter is very important. And the RV area also must be done in apical 4 chamber. And in apical 4 chamber, you actually use the end diastole, and normal should be less than 28 centimeters per second. That is in end diastole. Remember, during diastole, the myocardium has relaxed, so we expect this figure to be more, and the cavity is quite bigger than when it's in systole. And the RV area systolic, end systolic, it should actually be less than 16 centimeter squared. Remember, this is area. Why is it small? Because the cavity, the myocardium has contracted, and the cavity actually reduces into size. And then when you are also picking this RV wall thickness, you also have to remember that there are cases in where you can have RVH, right ventricular hypertrophy, in different pathologies that may present on the right side of the heart. And that also has to be quantified when particularly that has been asked, so that you comment in your report. So when you are measuring your RV wall thickness, this is actually how you pick it. This is a subcostal view, and you can see that it is well delineated. We can see this free wall. So you measure from outer to outer, and you pick your thickness of the RV wall thickness. This is very important so that you can comment on specific things and exactly know what is happening. So this is a subcostal view where you have to measure your RV concept. When it comes to the RV cavity measurements, there are 3 measurements that you can see. So from here to there, I've already mentioned, this is the length. It must be around 7.9, less than 7.9 centimeters. That is from the base up to the apical. And then this is the mid. I think I explained about the mid. And then this is also the base, which should be around 3.3, less than 3.3 centimeters. So this is the standard parameters on how you can measure the right ventricle when it comes to the quantification. When it comes to the area, the technique is to make sure you get your apical 4 chamber or apical 2 chamber. When you pick your apical 2 chamber, you pick actually 2 images. You freeze the other one, and then you also get the other one on the other side, and then you track back. When you track back, make sure you track back so that you get your image in diastole. And when you trace in diastole, make sure that you don't include the trabeculated morphological structures, which I mentioned earlier, because that may actually distort and compromise your calculations. So once you track that, you find that the cavity here is actually more bigger because this is in diastole. And this is the one I was telling you, it should be at least less than 28. Other parameters, they can actually give you 28 to 30 or 32 centimeters. So this is also very, very important when you are doing your left ventricle heart assessment size dimension. When it comes to the systole and diastole and systolic, remember I mentioned that you also have to track, make sure that you get your image by tracking back. You're also going to find that you're also going to have these parameters in centimeters squared. What are we trying to say here? What are we trying to achieve here? We are trying to achieve and quantify the sizes that whatever we are doing, we've actually done it. Sometimes it's very tricky when you put your measurements in your echo reports and you actually never did that, because you won't be able to justify exactly what you've written. So the point I'm trying to emphasize is that when particular clinical question has been asked, you have to ensure that you comprehensively exhaust and do the standard work on that particular part of examination that has been requested. And when it comes to the assessment of the right ventricle function, like I mentioned in my preamble, there are quite a number of methods that are done to quantify the right ventricle function. But for the sake of the discussion and for the sake of simplicity, I'll just discuss one method and then comment some few things that are there. I should mention here that when we are writing our reports in echo, we actually mention that the left ventricle function is this, and this, and this. And then half the time, sometimes we don't even quantify the function part of the right ventricle. You also agree with me that I think sonographers, cardiac sonographers, radiographers, we've been using surrogate parameters to quantify the right ventricle function. So sometimes we don't actually have the actual, we just look at it, eyeballing, and then we confirm what is there. But the key message here is that we can do some few parameters that can help us to see the quantification. So I'm going to discuss the TAPS. TAPS, this is actually tricuspid annular plan systolic excursion. The question is, how do we do this one? This is a parameter that is actually validated, and it has also shown correlation with the right ventricle ejection function when you do radionuclide angiography. It has also shown correlation, quite a strong correlation with the Simpson method, where we use the M mode to quantify the function of the right ventricle. But why am I discussing about these TAPS? Because it's one of the simple way of checking right ventricle function. So you do it with Doppler. So you get your apical 4 chamber, get a good standard apical 4 chamber, and you put your M mode. You put your M mode on the lateral tricuspid annulus, just at the lateral tricuspid annulus. So you put your M mode there and then you just update it. You are going to find that it's going to give you an M mode image where you can measure. Maybe for the sake of definition, again, I can define what this TAPS is. So TAPS is nothing but the difference or the distance in which the annulus, the lateral annulus, moves from the base to the apex. So there's that difference, the difference or the distance the annulus moves from the annulus, tricuspid annulus, towards the apex. So we measure that distance, and that distance normally it should be more than 17 millimeters. Others, they'll give you parameters like 17 to 20 millimeters. It is considered normal. The higher the displacement, I'll show you the image. The higher the displacement, the more functional the right ventricle is, or the functionality of the right ventricle is. And you also have to be very careful when you are using TAPS, because TAPS is the angle dependent, and sometimes this angle dependent may also be disturbed due to the motion of the heart. And then these taps also can also be increased in the presence of tricuspid regurgitation. And these taps also has also been shown that it's actually well correlates with the right ventricle ejection fraction when you're using the simple method. And more importantly, you also have to be aware that these taps that we are talking about can also be very useful when it comes to quantification of that. So it's very easy to do. And the other method which I want to discuss and show is the fraction area change, which is also called the FAC. And this is also very important. It has also been validated with myocardial performance index, also known as the TEI index. So you find that MRI becomes a gold standard when you want to quantify the right ventricle function. But the question is, do we have MRI in all the centers? The answer is no. So as much as we are using these parameters, we also have to be aware that in cases where they have to quantify, we can also now refer to these cases. No wonder it's very, very important for somebody practicing cardiac ultrasound to know that certain parameters on echo, they are actually limited and they may not actually give the true picture or the true accurate of that particular image that you're doing. However, I should mention here that these parameters, they help us to have at least a clue on how you can quantify this. I should also mention that this fraction area change does not actually quantify systolic global function, but it also helps you to just quantify regional global wall motion. So these two parameters becomes very key and they are very simple to do. So this is how you do, oh, sorry. Sorry, the image was not uploaded. Sorry for that. But I think I'll show you there's an image on TAPS on how to measure. It's very simple. When it comes to the right atrium echo windows, they are very simple. They are best visualized on parasternal long axis, inflow view, parasternal short axis, aortic valve, and the apical four chamber and the subcostal view. So again, what do we need to look at? Check the size. Do we know the normal size? We also have to check the right atrium pressure. You also have to know the normal variants, things like the Eustachian valve, the Chari network, and also assess if there's any presence or absence of masses. This can be a tumor or a thrombus as you are checking for the right atrium is very, very important. Some patients are sent to cardiac ultrasound basically to check for pace-wire venous catheter. For those with pacemakers, you can also check for those. Maybe they just want to see if the pacemaker is in situ. So cardiac ultrasound may also be requested for that, specifically to look at that. So things must also make sense even as you look at those things. What are some of the measurements that you need to take for RA dimension? For the right atrium minor measurements. Now, this minor measurement, this is the one that you get from the lateral wall of the right atrium to actually the arterial septal line. This is the minor one, and the major one actually moves from the annulus to the posterior wall, and those are the parameters. For the minor one, it should not be more than 4.44 millimeters, which is 4.4 centimeters. And the major one, it should not be more than 5.5. They are considered to be abnormal. Why am I emphasizing on that? Sometimes just the measurements or the dimension of the right atrium can also help you to know the pressures within the right atrium. So pressure quantification can also be based on the volume of blood within the right atrium. Very, very important. So these are the measurements from here to there, which is the major axis that is coming from the tricuspid valve up to the posterior wall. So this measurement must be less than 54 millimeters or 5.4 millimeters. And the minor one from here to there, you can also notice that it should be more than less than 44 millimeters or 4.4 centimeters. And always make sure that you optimize your image I've actually seen sometimes our practice of echo, we don't optimize, you get a foreshortened chambers. So once you get a foreshortened chambers, you may not get the actual quantification. I should also mention here that echo deals with very, very small figures. So any poor technique may actually result in the poor diagnosis, because it's those measurements that you are going to give out, and the measurements are actually going to help you give a diagnosis. So wrong technique may result into underestimation or overestimation of that particular parameter. And those parameters, they are actually the ones that you are going to apply, and you give a wrong diagnosis. So I'm emphasizing on the point of let's optimize our images and also get the standard chamber so that we quantify everything. This image, I was just trying to also demonstrate how we can appreciate the right atrium. This is a short parasternal access at aortic level. And then this is our right ventricle outflow tract. Remember, I talked about quantifying the right ventricle. So you can measure the right ventricle from there to there. You can also measure as you go towards the pulmonary artery. So this is also the RVOT, but the emphasis here is that you can actually appreciate the right atrium where you see these the tricuspid valves and quantify everything from there. What are some of the causes of the right atrial dilatation? You can have RA pressure overload due to pulmonary hypertension. We can explain it how this dilatation may come about due to increase the pulmonary vascular wedge pressure. You can also have this pressure overload that may result into the backflow of blood into the right atrium, resulting into the dilatation of the right atrium. So just by looking at the right atrium, you can also look at other parameters and then quantify how much pressure is coming towards the right atrium. You can also check the volume of the right atrium. This can be due to the volume overload. This may result due to tricuspid regurgitation or chronic atrial fibrillation or an ASD. The question is, how does tricuspid regurgitation result into volume overload? This should be due to the backflow, and the fluid, the blood within the right atrium is going to dilate our right atrium. And this may actually result into what I mentioned at first, where you can have the bowing of the atrioceptor line towards the left. On a 2D, just on a 2D, you are able to tell that the pressure and the volume, there is pressure volume overload. And then how can this chronic atrial fibrillation result into RA dilatation, due to those uncoordinated electric impulses? So the emptying or the preload of the right ventricle may actually be affected. And once the preload is affected, you are going to have poor or inadequate emptying of the right atrium. So you are going to have fluid overload within the right atrium, and this may actually result into dilatation of the right atrium. How does an ASD result into an RA dilatation? This can be due to left to right shunt when you have this ASD. So when you have, remember on our left side, we've got higher pressure than on the left. So when you have a defect, which is an ASD, you also have this pressure that is exerted towards the right, because it will be a left to right shunt. And then you also are going to have this dilatation of the right atrium. So basically what I'm trying to emphasize is that you look for specific causes of the right atrium that may actually help you to diagnose that this is what is happening on this side and this is what is not happening on this side. Certain things that you have to look at when you are looking at this pressure, the right atrial pressure quantification. Maybe I should also mention here that why do we need to talk about the pressure within the right atrium? It's very important because this can help us to quantify pulmonary hypertension, because we use a simplified Bernoullis equation to actually come up with the certain parameters and quantify pulmonary hypertension. So there are quite a number of methods that are used to quantify the right atrial pressure. And I'm going to discuss some few with specific points that we need to take note. One of them is the estimation of right atrial pressure using the IVC internal diameter. This is actually applied when you are talking about the compressibility index. Personally, in my reports, I include the IVC and indicate whether it's collapsing less than 50% or it's collapsing more than 50% or it's non-collapsible. The reason is very simple. The IVC collapsibility index is directly proportional to the pressures within the right atrium. How do we explain this? During Valsalva maneuver, or when you do a forced inspiration, you are going to have, physiologically, you are going to have the increase in the intra-abdominal pressure. So this increase in the intra-abdominal pressure will actually push a lot of blood, or it will actually increase the pressures within the right atrium. And when this pressure in the right atrium is increased, it makes the IVC to collapse. And that collapsing that's what we are referring to as the collapsibility index. So just by eyeballing, you are able to tell if the IVC has collapsed in diameter more than 50%. Just by eyeballing, you're able to tell if it's collapsing or it's not collapsing. And then if it's not collapsing during Valsalva maneuver, where you tell the patient to sniff, you find that you're also going to tell the diameter of that particular part. So you measure the IVC internal diameter both in inspiration and also in expiration. You realize that I've given this range because you measure the diameter of the IVC in different physiological process. So in inspiration, at normal, at rest, it has to measure within 15 millimeters. And then during expiration, it has to measure around that. And the cutoff point is that when the IVC internal diameter is non-collapsible, you're also going to quantify. So different diameters and pressures within the right atrium corresponds to the IVC internal diameter. So IVC internal diameter can actually be used to quantify or give an approximation of pressure within the right atrium. I'll explain further when it comes to that. The second method is that using the constant value of 10 millimeter mercury can be assumed as the RAP pressure. On this one, again, I have to emphasize some few things. Normal pressure within the right atrium, it should be around 3 millimeter mercury. But some literature will also give you a range. A range will be 3 is considered to be the normal. Then you can also have 5 and 8, which is also referred sometimes as the intermediate, and the upper limit, which is a 10 millimeter mercury. So what is the disadvantage of using this method? The disadvantage of using this method is that for those of us who are practicing echo, you find that we tend to get this upper limit, normal upper limit, which is 10 millimeter mercury, and then conclude on the pressures within there. So this one can actually be very tricky because you can either overestimate pulmonary hypertension or underestimate pulmonary hypertension. So I advise that as we practice this, better we use the upper limit, and anything above 10, around 15 millimeter mercury, that becomes abnormal. So for example, if I have my pressure gradient across the tricuspid, where I'm having the TR, tricuspid regurgitation of maybe 10, and then I should come and add, I'll show you the formula, I'll come and add this 10, and then I'm likely to have 10 plus 10, it will be like 20 millimeter mercury. So that will be considered normal. But there is a simple formula that you can use when you want to obtain this method. So this method is also very key, where I use a constant value of 10 that is assumed as the RAP pressure. The third one is the RP, the right atrial pressure, can be gauged by examining the patient's neck, assessing the jugular venous pressure. This is more done clinically for those who are clinicians and who are assessing this. That can be done, though this one has got also challenges depending on the anatomical or structures of certain individuals. Sometimes the sternal angle, which is the reference point, can actually be higher or lower. So this one may not be very useful for cardiac sonographers. And using the RA size to estimate RAP, which is usually normal around the less than 10 millimeter mercury. So this point again on number 4, it simply means that when you measure your RA size, that is when you do your dimension, those dimensions, when they are within the normal limit, it simply means the pressures within the right atrium, they are below 10 or around 10 millimeter mercury. So just to explain this second point about RA, we actually use the simplified Bernoullis equation. So this is a very simple equation. So RV, which is the right ventricle systolic pressure, is equal to 4 multiplied by the velocity squared multiplied by the RA right atrium pressure, where RA pressure is considered as a constant, this one. So we put the constant here. Then this formula is dependent on the tricuspid regurgitation. So you measure your TR, tricuspid regurgitation, you measure that one as a velocity, and then you square it and multiply it by 4. The figure you are going to find, you add it to a constant 10. So that constant 10, that will give you the right ventricle systolic pressure. Now, the question is, right ventricle systolic pressure is also equivalent to the pulmonary pressure, pulmonary systolic pressure. So this equation will actually help you to quantify pulmonary hypertension. No wonder I was emphasizing to say it's very tricky when you are using this equation, because this assumed constant of 10 millimeter mercury may not be the actual figure, because you have the normal pressure within the right atrium, which is 3 normal, 5 is considered normal, 8 is considered intermediate, and the 10 is considered the upper limit. However, it is also safe to make sure that you know and correlate with the clinical picture of the patient and consider the TR. I hope I've emphasized this point. This formula depends so much on the TR. And don't worry, the machine does all the calculations. You don't need to stress and do everything. The principle that you need to have is that the RV, right ventricle systolic pressure, is equal to the pulmonary artery pressure. And that pulmonary pressure is very crucial to help us quantify pulmonary hypertension. Now, again, you also have to know that why do we need to estimate the right atrial pressure? Again, it helps us to assess the tricuspid regurgitation and measure the peak TR. Why does it matter if we just use 10 millimeters for every patient? I've already explained that this may not be accurate, because it actually gives you those parameters that can be quantified with those. And then the other thing that we must understand, that echo is a non-invasive procedure or modality. The golden standard to quantify this pulmonary hypertension that I'm talking about is catheterization of the pulmonary artery, where you find that. And then you find that this is an invasive procedure. So echo becomes so handy, so that we can at least have a clue and know what is going on. And then I've already mentioned that the right ventricle systolic pressure helps us to determine or diagnose pulmonary hypertension, which becomes very crucial when patients presents with such. What does the IVC have to do with RA, which is right atrium pressure? I've already explained that IVC helps to determine the central venous pressure, the venous flow, and exactly what is happening within the right atrium. This is also achieved by collapsibility index. How to correctly measure the IVC on echo? It's very simple. You use the subcostal view window. You can also use the sagittal view of the IVC, and then you measure the IVC diameter at least 1 to 2 centimeters away from the right atrium. The question is, how are you supposed to do it, and why should you do it away from the right atrium? So this is where you measure. This is our right atrium. We are using the subcostal image. So we are using this. So the distance from here to there, approximately, it should be around 1 to 2 centimeters. So you measure from here up to here. This is the diameter and how you measure. Collapsibility index can also be observed just by eyeballing and looking at how it's collapsing. So this is very key to note this. Sometimes this actually gives you, within a short 2, 3, 4 seconds, you get your quantification. Again, this is where you get your collapsibility index and check what is happening there. I talked about applying the M mode when quantifying the IVC. So when you look at this is in expiration, and then this is in inspiration. So the diameter from here to there is not the same diameter from here to there. This is more reduced, and this is more higher. So you consider those, and you can see the technique. Approximately, it was around 1 to 2 centimeters away from the right atrium. Again, the beauty with the M mode, it will actually give you all those, the pre, the post, and the diameter of the IVC during the sniffing and the inspiration and the expiration of it. So you can see that it's collapsing. This is the collapsing that I'm talking about. So the distance from here to there, we can consider it as 100%. So if it can collapse halfway, this is what we can call collapsing 50%, more than 50%, then we can tell that, oh, the IVC pressure, they are within the normal range. It's between 3 millimeter mercury to around 8 or to around 10. So the collapsibility index becomes very crucial. And these are some of the things when you comment on the IVC in your echo report, justify why you are doing that, and so that it's well understood. How do we assign the RA pressure value within the parameters? So the normal right atrial pressure, like I mentioned, is assigned when the IVC is in normal size and collapsible. I've already mentioned that. So normal is considered to be normal when the right atrial pressure is within 3 millimeter mercury. And when the IVC is less than 2.1 centimeters or 21 millimeters, then the pressures within the right atrium is considered normal. If the IVC collapses more than 50% with sniff, this is also considered to be a normal, you have normal pressure within the right atrium. When do we say the pressure within the right atrium is high? When it's around 15 millimeter mercury, which I mentioned. So high right atrial pressure is assigned when the IVC is dilated with no collapsing. How do you know that this is dilated? You measure using your M mode. You quantify it using your M mode, so that you see if it's above 25, if it's above 23, you consider that it's dilated. If the IVC is above 2.1 centimeters or 21 centimeters, this is considered dilated, and the pressure within the right atrium is around 15 millimeter mercury. And then you also have to check that the IVC collapsing less than 50% with sniff. This may also be an indication that the pressure within the right atrium is increased. Intermediate, I talked about the intermediate right atrium pressure. The range ranges from 5 to 10. This is also regarded as quite intermediate. I've already talked about the reference point. So this is considered normal pressure within the right atrium. This is considered the intermediate. This is considered high. And this is abnormal. This is abnormal. The intermediate one is considered normal. And these are IVC collapsing. So the IVC will also give you those parameters. I talked about the things that you must look at in the right atrium. One of them is the Eustachian valve and the Cherry network. Remember, embryologically, the Eustachian valve, this is just an embryological remnant that is found within the right atrium that directs blood, as the blood has to bypass the immatured lungs and go straight to the left atrium. So you find that you can have what we call a Eustachian valve, and this should not be indicated as an abnormality or a lesion. This is a normal finding that you can find. And the Cherry network as well, you can also find it. And this normal finding on echo can be mistaken for a thrombus or a vegetation, because this Eustachian valve, it looks very weird. And then if you are new in the practice of echo, this may look weird, but that should not scare you, because that should give you at least an indication you are dealing with a Eustachian valve or it's a thrombus. If it's a thrombus, presentation also will depend. The clinical history of the patient has to also be followed so that you are within the normal parameters. Again, the Cherry network it also appears almost like the Eustachian valve. It's a fetal remnant that looks like a web-like structure, and it will also look like it's a dangling lesion within the right atrium. It can extend actually even up to the right atrium with attachment on the IVC junction. So those lesions may be seen. So this is a Eustachian valve. It actually appears a linear appearance, echogenic within the chamber. Those are the things that you can look at. This is a Cherry network. Still, this is considered normal. It's a normal variant that you may find within the right atrium. Tricuspid stenosis, these are some of the things that I just wanted to show. We know what they are, but they may also be very crucial when you're assessing the right atrium. The tricuspid regurgitation, effective endocarditis, tricuspid valve prolapse, Epstein anomaly. These are topics that we cannot exhaust in one lecture, but there are certain things that you look at. When do we say there is an Epstein anomaly, there is this, there is that? There are specific parameters that you need to look at. Now, when there is tricuspid stenosis, again, you look at the parameters. The quantification of tricuspid stenosis is actually the same the way we quantify with the mitral valve. Just like the way we quantify the tricuspid regurgitation, it's also the same the way we quantify mitral regurgitation. We look at the 4 parameters. We can look at the vena contracta, we look at the length of the jet, we also look at the flow convergence, and then we also look at the velocity diameter of that particular. So there is nothing strange about quantifying the TR and the TS, the tricuspid stenosis and the tricuspid regurgitation. So you basically look at the area. Normal area, it should be around more than 0.7 centimeters. If it's severe stenosis, it will be less than 0.1. Tricuspid mean gradient, we also consider it to be more than 5 millimeter mercury or equal to that. So this is how you pick your tricuspid regurgitation. For those who are practicing echo, this is very simple. Make sure you get your apical 4 chamber, apply your pulsed Doppler there, and then you're going to have this wave just below the baseline. This is our baseline. That is our baseline. Below the baseline, you are going to have this regurgitation. So you put your catheter just there, and then the machine will do everything. So you can see I'm having a pressure gradient of 27.9 with maximum velocity of 2.6 meters per second. So when it comes to this, the moment you put your catheter here, you calculate here. Remember, I mentioned that the simplified Bernoullis equation uses uses the TR regurgitate. It uses the TR, the presence of the TR. So the pressure gradient of the TR is 27.9. Now 27.9, already it has done the calculation. If I have my constant RA, right atrial pressure, which is 10, I'll just add to this pressure gradient, and I'm going to have 37. I'm going to have 37. So pressure gradient of 37, that is on the milder part. It's slightly increased pulmonary hypertension, because we know that the right ventricle systolic pressure is equal to the pulmonary arterial pressure. So this, just from here, I'm able to quantify how much pressure is within the pulmonary artery. I'll just add 10 as a maximum, or I can add around 10, 8. So this figure is very key. But for example, if I get my pressure gradient of 40, already 40, even if I don't add, even before I add my 8, my 10, my 3, still the pressure gradient of TR will be very high. What does it mean to me? It simply means that the right ventricle systolic pressure is around 40 something, and already that is the pulmonary hypertension. So it becomes very simple to quantify, because on this one, I just wanted to show the pulmonary saddle embolus. How do I quantify that on echo? You use your short parasternal axis at aortic level. This is the RVOT, the right ventricle outflow tract. And then just around here, you are going to find your pulmonic valve. And then as it comes here, this is going to be the main pulmonary artery, which branches to the right pulmonary artery and the left pulmonary artery. So when you see here, there is an echogenic lesion here. So this can also actually help you to pick an embolus. It's very difficult on echo to actually pick an embolus beyond this level, because the diameter of these arteries down here, it's actually very narrow. So you actually pick it around. It's a common site for an emboli, which can be visualized on echo. So echo plays a role actually even before you suggest to go and do a cath lab. It can actually help you to pick something, but beyond that, you can actually not see. So I'll still repeat. This is the RVOT pulmonic valve, main pulmonary artery. You can actually also measure the diameter here, the diameter of the main pulmonic artery. It should not be more than 2.1 centimeters. Once it's more than that, you can tell that this is dilated. This is where you measure your diameter of the pulmonic artery. It's also very key to note that these issues must also be considered when you are looking at the parameters that are involved. Okay, again, still, this is the main pulmonary artery. This is an embolus, the right pulmonic artery. Then this is the left, bifurcating from there. I talked about the enlarged right ventricle. You can measure it from there up to there. We talked about it. And then you can see that there is flattening of the IVS towards the left ventricle. Again, that is flattening of the IVS. This is a picture that can give you a D-shaped. This is not a proper D-shape, but once you see a D-shaped in short parasternal axis, you actually know that there is pressure overload. And then the pressure within the right ventricle is increased and it's exerting on the IVC. This is something that can also help you. And lastly, the famous pulmonary hypertension. We know that pulmonary hypertension can actually be defined hemodynamically, and we must also know exactly what this pulmonary hypertension is. So it's nothing but the increase of blood within the pulmonary vasculature, and the pulmonary hypertension with mean pulmonary arterial pressure of less or equal, greater or equal to 25 millimeters at rest is considered raised when it's like that at rest. If it's less, if it's equal or more than 25 millimeter mercury at rest, it's considered to be normal. Again, I'm just emphasizing the simple Bernoullis equation, which I was talking about. The right ventricle systolic pressure, that gives us the 4 multiplied by the velocity of TR. You square it, you are going to have your pulmonary pressure. We can hemodynamically define it as a mean pulmonary arterial pressure, 25 millimeters at rest. It's considered to be normal or near normal pulmonary capillary wedge pressure. What is capillary pulmonary wedge pressure? This is the pressure that is within the pulmonary vasculature, and this has also a lot to do with the pulmonary hypertension. And the mean pulmonary arterial pressure of 30 millimeter mercury during exercise is also considered normal. On echo, mild pulmonary hypertension is regarded as pulmonary hypertension with arterial systolic pressure between 36 to 50 is considered to be a mild pulmonary hypertension. We also have to note that introduction of the right catheterization is the gold standard to quantify the pulmonary pressure. I think I mentioned this. And then the post-capillary is the most common cause of pulmonary hypertension. This can be due to quite a number of etiologies. And then lastly, the major causes of pulmonary hypertension, they are in 5 categories, and I'll briefly mention them and give a reason why they cause that. So the pulmonary arterial hypertension, this is one of the common causes of pulmonary hypertension. This may result into increased pulmonary vasculature hypertension because there is raised pressure within the pulmonary vasculature. Then you can also have the pulmonary venous hypertension. This may also result into that. Lung disease, which is chronic obstructive pulmonary disease, is also one of the common causes of pulmonary hypertension. I should also mention here that with the prevalence of post-COVID effects due to lung fibrosis, we are likely to have a raise or an increase of pulmonary hypertension, because one of the causes of pulmonary hypertension is actually lung disease. And you also agree with me that research has shown already that causes of pulmonary hypertension is actually lung disease. One of them is being lung disease. Okay. Then we can also have the screening. You can actually use echo to actually screen patients with pulmonary hypertension. I think those I was just giving. When PHT, when pulmonary hypertension is unlikely, if tricuspid regurgitation is less or equal to 2.8 meters per second. Pulmonary hypertension, which is abbreviated as PHT, is also possible if TR velocity is 2.9. And then PHT is likely if the tricuspid regurgitation is more than 3.4 centimeters, with systolic pulmonary arterial pressure of more than 50. And then if you have an IVS flattening, you are likely to have suggestive of PHT. Then you can also have the parameters of pulmonary hypertension, which can be due to, which can be due to hypertension. And echo provides a variable non-invasive methods for estimating this pulmonary arterial pressure, which I've already discussed. The technique depends on the presence of TR. And then I've already explained this. Okay, I've already explained this. This one, I was just trying to give an example on how you can look at the TR. Sorry. My slides, sorry. So basically, the presentation is almost done. As I look for this, I can actually conclude as we wait for this to come up. So the point I'm trying to put across is that, in conclusion, it's very important that as long as qualified sonographers and physicians and those of us who are practicing echo, we don't function as a team, the full potential of echo as a diagnostic tool will not be realized. So we need to work as a team, as cardiac sonographers, radiographers, and those of us who are practicing echo, as a team with all those who are referring patients to us, so that the full potential of this cardiac ultrasound can be realized. And also it's very important that as we do our cases of pulmonary hypertension, we also have to look at certain specific parameters. And even as we conclude, to look at specific orientations of our cardiac ultrasound.
Mr. Mulenga. Is it only me who has lost him?
No.